Cognition is one of those, and today we're going to focus on the cognitive aspect of this condition. And with a prelude, telling you a bit what I'm going to tell you in a second, let me tell you a story. When I was a graduate student working on a PhD way back in the late 80s and early 90s, my PhD advisor, a massively successful scientist in his own right, told me, you know, don't propose to do the things that are popular now. You need to think what's going to be popular in 10 years and do those studies. And that was the extent of the guidance I got. So he didn't tell me how to read the future. But if I had to read the future and predict what will historians of the 22nd century write about the biggest developments in brain science of the 21st, the lead story of 21st century science is neuroplasticity. We all know neuroplasticity because we all lived it. Let me give you some examples of how you have lived neuroplasticity. You were born into the world not knowing anything, and you learned to walk and coordinate your limbs, and by the way, speak a language, which is an amazing thing, and your brain did it effortlessly because it was forced to decode the sounds that everybody else was making. And eventually, and that's the thing, if you tell your brain keep to do something, your brain will mold itself to achieve that goal. Right now, I could not run a marathon, but if I were to simply have a practice of running a little bit every day and increasing that over time, there's no doubt that I could run a marathon. The body, like the brain, will change itself, it will adapt itself to the requirements that we place upon it. The root word of plastic means moldable. And neuroplasticity then formally means the ability of the nervous system to rewire itself. And we do this all the time. We talked about there, learning English, learning how to multiply. If you ever learned a foreign language, you engaged your neuroplasticity. If you don't currently speak one, you have no doubt that you could learn one. It just takes a goal and a system and regular daily practice. So all those things, and we can apply them, and we are applying them to psychiatric care in the form of mindfulness, learning to recognize one's emotions, learning to recognize one's thoughts. And once learning how to recognize these things, we can actually control them, or we can modify them in ways that nobody gives ourselves credit for. So in fact, the essence of dialectical behavior therapy for the thing I call emotion regulation disorder, which the DSM still wants to call borderline personality. But for that condition, the essence of DBT is to learn to recognize one's emotional states and thoughts, and to engage in regular practice to regulate those thoughts and emotions. And guess what? In functional MRI scans, people who do that rewire how their amygdala works. The amygdala is what controls fearful or negative emotion. And people who would engage 12 months of nothing but textbook DBT have different amygdala function, and it goes along with better ability to regulate emotion. So like I said, we're just at the very beginning of being able to harness this therapeutically, but it really does get to the root of the issue. And when we get better and better techniques, as I said, that's what 21st century is going to be all about. And neuroplasticity, by the way, explains a whole lot of what gets passed off for so-called neurotoxicity of schizophrenia. You've heard, no doubt, that the longer one spends in a state of psychosis, the worse the long-term outcome is going to be. That's technically true, but the effect size is relatively small. I'll talk about effect sizes later, but keep this in mind. The effect size of that relationship is about 0.2. I'll come back and explain that in a second, in a few minutes. But because of this relationship, they had this idea that schizophrenia or psychosis is inherently toxic and that there's some form of brain damage that happens. And actually, it's never been really well described. Most of the predictions that you make on the idea of a toxic process don't show up in the real world. Rather, neuroplasticity explains a whole bunch of it. So the longer you spend with the belief that I can't trust people, the more your brain wires itself around presenting you with those ideas. So it's not damage, it's just learning. And the great thing about thinking about learning or unlearning, depending upon what happens, but the great thing about framing the long-term poor outcomes from untreated psychosis through a plasticity lens is that it gives you tons of actionable ideas So we no longer have to say, oh, the brain is damaged, all is lost. No, we understand that a person has lived with a certain set of beliefs for 10 years, and we need to come up with alternate beliefs that are more believable and rehearse those. And as you rehearse new things, then the old things fade away. So it gives you a lot of power. And we can apply this, as you'll see, to addressing the cognition issues. So cognition means a lot of things. I'll explain in a second what those are. But it's important to think about cognition in schizophrenia, because when you design studies to say what facets of this condition are most associated with functional impairment or disability, the negative symptoms, which we talked about last month, and the cognitive symptoms come up as the dominant factors. Surprisingly, positive symptoms like hallucinations are tiny compared to the impact of cognition or negative symptoms on long-term outcomes. And we tend to not, it tends to be overlooked when we design treatment programs or clinical care. Unfortunately, still today, most of schizophrenia treatment revolves around medicines, which can be fabulously helpful for addressing the positive symptoms like hallucinations. But those medicines don't really markedly touch the cognitive issues. So since we don't actually have any medicines that the FDA has approved for marketing for cognitive treatment, it's a kind of a problem that we struggle to fix. And I think there's also an undercurrent of, why bring something up if I don't have the tools to make it better? So nonetheless, it's worth to think about and try to address, because it matters. The things that I'll talk to you next come from this, well, they come from several sources, but many of them come from this open access review article, and we will send a PDF of these slides to you, and in the PDF, that hyperlink there should be active, so you can link to the study itself on the internet, or you can just Google that title, and you'll pull it up yourself in an internet search. So cognition, as I said, broad thing. It encompasses a lot of different facets, like how fast one executes cognitive processes, processing speed, attention and focus, the ability to learn, like how rapidly can I acquire and store information. So that would be learning. How long do I retain the information once it's in there? Memory, and then higher level processes of how do I solve complicated problems, applying the things that I've learned separately to bring them as a whole. That oftentimes is lumped under something like executive functioning or just plain reasoning. And then social cognition, understanding, which involves being able to perceive body language, facial expressions, understand the unspoken meanings of certain things, and take that data and put it into the problem-solving or executive function domain. So when we talk about cognitive impairments in schizophrenia or cognition, keep in mind, it's a whole lot of stuff under that hood. And it's also important, I won't spend on this one. The social cognition I explained, it's a very important factor in long-term outcome. The thing with schizophrenia in general is that I can say the research shows this, but a research finding, no matter how strong it is, doesn't apply to everybody with a diagnosis. So a classic example is enlargement of cerebral ventricles. There are fluid spaces in the brain which have been shown to be bigger in people affected by schizophrenia. So the flip side of ventricular enlargement is loss of brain tissue. Probably more accurate to say the former than the latter, but we'll say there is a CT. You can see this on CT scans, and it's been repeatedly demonstrated. So we say schizophrenia goes along with enlarged ventricles. And statistically, on average, that's true. But within 100 individuals, you might find 40 that have that finding and 60 that don't. On the average, they come out as bigger, but I'm saying there's a lot of diversity under the diagnosis of schizophrenia. Similarly with cognition, on average, get 1,000 people with schizophrenia, give them a cognitive testing battery. The average score of the entire group will be lower than the average score of a mesh comparison group. But within the group of people with schizophrenia, you'll find some people who are very impaired and some people who are hardly impaired. You'll find some people that have deficits in 7 cognitive domains, and you'll find somebody who has deficits in just 1. So I think it's important to recognize this, because it's not a one-size-fits-all. And when we say this happens in schizophrenia and we tell that to our patients, a lot of that can be very spooky, and it's more helpful to explain these sorts of things can happen. Not everybody is affected to the same degree. Some people are hardly affected at all. Just be aware that this is on the map. So I think it's important just to keep in mind the diversity within this diagnosis. So let's turn to specific ways to try to improve cognition. Can we help it with medicines? Sadly, probably not with any that we know. We have some medicines which are specifically designated to improve cognition in Alzheimer's disease, like donepezil or rivastigmine or galantamine. Those are the top medicines on that chart, on that table. But schizophrenia is not Alzheimer's disease. And those medicines that can be helpful in early stage Alzheimer's disease are generally not helpful in people with schizophrenia, because the process leading to the cognitive impairments is a different process. And here you see on this table a whole bunch of other medicines in the second column from the left, and different mechanisms of action, like different neurotransmitter targets on the far left column. The sad fact is none of them are really giving a reliable signal. So right now, nothing can be said to be helpful with any sense of reliability. So medicines, probably not a whole lot of improvement. They can do a lot of harm, though. This is a graph that shows on the y-axis a memory performance in terms of a z-score. So a z-score is kind of like a standard deviation, and you see here you see the graph of memory scores on a group of people that were taking cogentin/benstropine, the most common side effect medicine for people who take antipsychotic medicines. So on the far left, you see how it was at the beginning, and then with continued time off of the benstropine/cogentin, you see that it rises by about 1/2 of a standard deviation, which, as standard deviations go, is quite a lot of brain power. So the bottom line is that we will prescribe medicines like benstropine/cogentin or other so-called side effect medicines for the side effects of antipsychotic treatment. For the prescribers in the room, if you dose people to the point that they have such symptoms like extrapyramidal symptoms, probably that dose is a bit too high. You can generally achieve improvement, if not remission, of psychotic symptoms at doses that equate to 60 to 70% coverage of dopamine receptors. You don't usually see extrapyramidal side effects until you get to about 80% coverage of those receptors. So generally, we can avoid using medicines like benstropine or cogentin if we avoid polypharmacy or excessive dosing. There are always exceptions to everything, of course, but as a general rule, less is probably preferable than more. And if you cannot be on a medicine like benstropine, which has a well-known side effect of impairing memory, so much the better. Going back to my graduate school days, I mentioned, my PhD work was in drug development for Alzheimer's disease. And benstropine is a medicine which blocks the signal of acetylcholine. Acetylcholine, I call it simplistically a memory molecule. So studies were done in the 1970s where they gave anticholinergic drugs similar to benstropine to college students. They found that college students on these kinds of medicines will have memory performance which is on par with 70-year-olds. They found also if you give such medicines to 70-year-olds, they will have memory impairments which are on the level of Alzheimer's disease. And we don't give them to Alzheimer's patients because they become delirious. So the point of all this is that the cognitive impairing ability of standard so-called side effect medicines is significant. Not only in memory, but less commonly, but still reported, is that they may actually worsen psychotic symptoms. They have the potential to cause mood instability. And in general, they can they make tardive dyskinesia more likely. So if you can avoid, so we can't really help to improve cognition so much with medicines reliably, but we can reliably avoid worsening cognition by trying as best we can to avoid exposure to this category of medicine. So we talked about, coming back now to the things that are probably more useful, tapping into neuroplasticity. So how did we all learn multiplication tables? Generally, drill and practice. So here's an equation, 7 times 7. I don't know what this is. I say, oh, 49. So a flashcard technique, for example. I keep doing that, and then I form a memory which is longer and longer lasting, and over time it has become permanent. So the same thing applies no matter what the skills. So cognitive remediation in schizophrenia is based upon very simple underlying principles like flashcards to learn math tables. And just as DBT has been shown to change the function of the amygdala, which generates fearful and negative emotions, so have studies and MRIs of people with schizophrenia engaged in cognitive remediation shown that it changes the brain function in this condition as well. So we can, so it works, and it works even better when you're doing the drill and practice, generally these days with computer-generated brain games, when you combine that with real-world opportunities to practice them, like engaging in supportive employment. So you can train the brain to become a better learner, and then you can give it opportunities to apply that learning in the real world. So fabulous approach, and one that I think we should deploy across the board probably immediately, because we can save a lot of brains this way. Remember I said effect size. I'm going to talk now about the effect size, which is a statistical way to say how strong or how powerful is an intervention, or how strong is a correlation. The great thing about effect size is that the statistic is the same across the board. So what's the impact of the difference between the average height of an NBA player and the average height of somebody who's not in the NBA? You can actually get an effect size number to tell you that. And that gives you the same degree of bigness or the same degree of strength, no matter if you're comparing NBA heights, IQ scores, or effects of medicines, or relationships between duration of untreated psychosis and long-term outcomes. So again, remember, the duration of untreated psychosis versus long-term outcome relationship had an effect size of about 0.2. This, for reference, is the effect size of a whole bunch of different antipsychotic drugs on reducing psychotic symptoms of schizophrenia. Like almost all commonly prescribed psychotropic medicines, the effect sizes generally range from 0.4 to 0.6. In this case, I prepared this slide for a clozapine lecture. Clozapine clearly stands out with an effect size of 0.9. So let me again, for the benefit of understanding the meaning of effect sizes. Effect size of everything except for clozapine to treat symptoms of psychosis and schizophrenia is between 0.4 and 0.6. What's the effect size of an SSRI antidepressant like Prozac on the ability to reduce symptoms of depression or anxiety? About 0.6. And what's the effect size of this relationship between duration of untreated psychosis and long-term poor outcome? 0.2. So more than 0 to be sure. It's statistically meaningful, but it would be called a small effect size. Effect sizes of 0.4 to 0.6 are moderate. And just for reference as well, effect sizes of 0.9 to 1.0 are on par with the effect size of amphetamine to treat symptoms of ADHD. So in this case, clozapine is clearly the world's most powerful medicine. Oh, I honestly didn't plan this, but by the way, we're having a training on the 11th for clinicians who want to use clozapine. So that was really a serendipitous plug for. I truly didn't plan that. It just happened that way. But when I say we should use more than clozapine because it's the world's best medicine for schizophrenia, there's why I say that. So now that we've oriented you to effect size, what is the effect size? Like, how powerful is this cognitive remediation stuff? And I refer you to this meta-analysis. A meta-analysis is where you look at a whole bunch of different studies to try to get on average what the effect size is going to be. 0.45, all studies considered, 0.45. So again, That's on par with the effect size of lurasidone or acenapine or geodon or even Abilify. So cognitive remediation has an effect size which is on par with antipsychotic medications for different applications. Antipsychotics work for positive symptoms. Cognitive remediation works for cognitive symptoms with efficacy at 0.45. It gets even better because if you want to address the so-called very hard negative symptoms, you can see that you're also up to 0.4. The 0.4 is an estimate from the better designed cognitive remediation studies. So you can reduce cognitive impairments and you can actually reduce negative symptoms as well. And oh, this is something you don't actually have to hire a psychologist to administer. You just need to maybe hire a personal trainer and form some support groups in your clinics for people to engage in aerobic exercise and encourage each other to participate outside of the clinic. And aerobic exercise, well, let's see, effect size on cognition, 0.4 to 0.5. Which again is on par with the effect size of Abilify to reduce hallucinations. And the more you exercise, the bigger the effect. And on these bottom bullet points, attention/vigilance, the thing that people want to prescribe stimulants for, you get an effect size of almost 0.7, which is better than everything but clozapine in the antipsychotic chart I showed you. And social cognition, that thing that I said is not related to everything else, but yet is highly impairing. Social cognition in this study had improved, aerobic exercise improved social cognition with an effect size of 0.7. 0.7 is a big effect size. So, and so this is basically, if this was a medicine, it would be everything but clozapine, and it has no side effects. So the fact that we don't actually deploy this into practice is something that makes me, well, frankly, angry about our commitment to improving the lives of people with illness. Something clearly that everybody needs to think about because, as I say, schizophrenia is a condition which affects multiple facets of functioning. Drugs affect only one facet of that. So if you want to get full recovery, so that the parents of the kid that we talked about earlier aren't going to think my child is irreparably broken, rather my child can be restored to wholeness, which is an achievable goal. We just need to stop focusing on medicines as the dominant form of treatment. They are important to be sure. I'm a pharmacologist, so I can tell you that. But we need to stop thinking them as the root base of everything and give equal attention to doing the hard stuff, like forming cognitive remediation services in our clinics, and the easy stuff, forming exercise groups with mechanisms to encourage people to do stuff. So to summarize, cognitive issues are a thing in schizophrenia. They're not uniformly distributed. We can't really make them better, as far as we know, in a reliable fashion with existing medicines. However, we can avoid worsening them by not giving people medicines like benztropine/cogentin or benzodiazepines, for that matter. And the cognitive remediation and exercise are safe and side effect free, and there's no reason why we should delay getting them into practice across the land. So closing there with a little bit of editorial flourish, but still that's me